Everyone, welcome back to Izzy Medicine, where we make complex medical topics just a little bit more manageable, or at least we try to. Today, we're diving into the wonderful world of hypothyroidism. I know, you're already on the edge of your seat. So, grab your notes and let's break this down step by step. Before we talk about the abnormal, let's refresh a little bit about how the thyroid normally functions. The thyroid is a little gland located in the front of our neck that pulls a lot of weight in terms of regulating our metabolism. It produces two main hormones, T4, thyroxine, and T3, triiodothyronine. And these two little guys influence pretty much everything. They control how fast or slow our body uses energy, and that has a ripple effect on so many other bodily functions, which we'll talk about shortly. But before T3 and T4 can work their magic, we need to understand how they're actually made. Thyroid hormone production actually begins in the brain. The hypothalamus kicks things off by releasing TRH, or thyrotropin releasing hormone, which tells the pituitary to release TSH, thyroid stimulating hormone. TSH travels down to the thyroid, and it basically tells it, hey, time to make some T3 and T4. Once they're made, these hormones are floating around in the bloodstream, and they provide feedback back to the brain to regulate their production. It's a pretty cool negative feedback loop, and it keeps everything balanced when it works. That is. Now, let's zoom in, and we'll get into the nitty-gritty of thyroid hormone production inside the thyroid. So inside the thyroid, we have our follicular cells, where we have a protein called thyroglobulin and an enzyme called thyroid peroxidase. When iodine, which we get from our diet, enters the thyroid from the bloodstream, it binds to thyroglobulin with the help of thyroid peroxidase. And after a few interesting processes, ta-da, we have our T3 and T4. But when things go wrong in any of these steps, we're looking at hypothyroidism, low T3 and T4. For example, if there's no iodine, nothing happens because there's nothing to bind the thyroglobulin within the follicular cells. If we have damaged follicular cells, then we have no thyroglobulin for iodine to bind to and no thyroid peroxidase to facilitate the binding. So same result, low T3 and T4. So now that we understand a little bit of this, let's move on to the fun part. What causes hypothyroidism? Let's get going. Worldwide, iodine deficiency is actually the top cause of hypothyroidism. As we learned, iodine is actually essential in the production of T3 and T4. Without iodine, T3 and T4 production grinds to a halt because we have nothing to bind to thyroglobulin. TSH levels shoot up because the pituitary is like, what's going on here? And it tries to increase the amount of TSH to stimulate the thyroid gland to produce hormones. But without iodine, it doesn't matter how much TSH we have. No iodine, no hormone production, and that equals hypothyroidism. In the US, Hashimoto's thyroiditis takes the crown as the primary cause. It's an autoimmune condition where the body basically attacks its own thyroid. This attack causes inflammation and destruction of those very important follicular cells. So if we have no cells, we have no thyroglobulin and nothing for iodine to bind to, and of course, no hormone production. So we will see low T3 and T4, and again, elevated TSH as our pituitary tries to stimulate the gland. Here we may also see elevated TPO and thyroglobulin antibodies, as those are also attacked in the process by our immune system. Unfortunately, Hashimoto's usually leads to a permanent hypothyroidism because the follicular cells are permanently destroyed, and that means lifelong thyroid hormone supplementation. We also have postpartum thyroiditis, which is a condition that happens after delivery. So this is where the immune system, after being suppressed during pregnancy, goes into essentially a hyperdrive after childbirth. And this hyperdrive destroys the gland. And as the gland is destroyed, it releases all of its T3 and T4. This initially causes an overactive thyroid gland or hyperthyroidism, which we will discuss at a later lecture. After this release, the thyroid gets depleted and we swing into hypothyroidism with low T3 and T4, and again, high TSH as our pituitary is really trying to do its job. The good news here is that postpartum thyroiditis is usually temporary or transient. And as the immune system calms down, the attack on the thyroid stops and the thyroid goes back to normal function. Then there's subacute thyroiditis, which is a very cool condition. It's also called Decorvain's thyroiditis. And this is cool because it's triggered by a viral infection. So not only does our patient usually have an upper respiratory infection, but the virus can also attack their thyroid in the process. This causes fever and illness, but interestingly also, it causes a painful goiter or painful thyroid gland. And this painful goiter differentiates subacute thyroiditis from other forms of thyroiditis, which usually have a painless enlargement if they have one. And again, we will see low T3 and T4 and a compensatory elevated TSH. Lastly, as far as primary hypothyroidism causes, we have iatrogenic hypothyroidism. This is caused by medical treatments. For example, removing part or all of the thyroid for thyroid nodules or cancer can diminish the amount of thyroid tissue that there is, and it can cause low thyroid hormone production. Things such as radiation therapy or certain medications can also lead to low thyroid hormone production. But wait, there's more. In addition to primary hypothyroidism, there's also secondary hypothyroidism. This type of hypothyroidism actually happens outside of the thyroid, usually in the pituitary gland. So let's discuss. One of the conditions that can cause secondary hypothyroidism is a pituitary macroadenoma, which is a large, usually benign tumor. Because it is so large, it compresses blood vessels in the pituitary. This compression prevents the hypothalamus from sending a signal to the pituitary to produce TSH. This lack of signal reduces the amount of TSH production, and less TSH means less signal to the thyroid to release T3, T4, and we have low T3, T4 hypothyroidism. Unlike primary hypothyroidism, here we will see low T3, T4, but low TSH because our pituitary didn't release any to begin with. Another pituitary-mediated cause for hypothyroidism is Sheehan syndrome. Sheehan syndrome occurs usually from severe blood loss during or after childbirth. This severe blood loss reduces blood volume, and blood volume reduction leads to pituitary damage through ischemia or lack of blood supply. Because our damaged pituitary can't produce TSH, that in turn affects the production of T3 and T4 levels, and we have low T3 and T4 levels, and again, low TSH. Sheehan syndrome specifically damages the whole entire pituitary gland, and it will affect multiple other pituitary-mediated hormones, and we will discuss that on another day, an OBGYN kind of day. So now that we know a little bit about normal and the conditions that cause this, how do we recognize our hypothyroidism patient? So think of this as a puzzle, which is so cool because not only is hypothyroidism a puzzle, but all of medicine is a puzzle. And instead of putting pieces together, you're connecting symptoms together. So if you enjoy puzzle building, you are heading in the right professional direction. Let's go through some of the symptoms one by one. I am sure you're super excited. If our patient has a swollen neck on exam, or the patient themselves come in and say, I've noticed that my neck is a little bit enlarged, it might be a goiter. So a goiter is an enlarged thyroid gland, and as we reviewed, it could be painless or painful. And it happens because when T3 and T4 levels are low, the pituitary, as we know, pumps out TSH in large quantities trying to fix the issue. But because the thyroid can't produce the hormones, the thyroid in response just grows and grows and grows, trying to produce more thyroid tissue. This enlargement doesn't help, but it's the thyroid's way of trying to meet the body's demand. In subacute thyroiditis, it's a painful goiter. In Hashimoto's, postpartum, and iodine deficiency, it's usually a painless enlargement of the thyroid, a painless goiter. A very common symptom of hypothyroidism is fatigue. Our patient often will come in complaining that they're feeling absolutely exhausted without change in activity or sleep. Why does this happen? T3 is like a fuel for the body's energy production. It powers up ATP production, the energy currency for our cells, and boosts mitochondrial function. So when T3 levels drop, ATP production slows down and mitochondria works less efficiently. In turn, muscles, organs, and everything in between don't get the energy they need, and you combine that with a sluggish mitochondria, and you have a very tired and possibly even physically weak patient. Another commonly bothersome symptom, specifically bothersome to a lot of patients, is weight gain. And what the patient will tell us is that they haven't changed anything in their diet or exercise patterns, but they're gaining weight rapidly. Why does this happen? So T3 normally revs up metabolism. It helps burn calories more efficiently by breaking down fat and carbohydrates. When T3 levels are low, metabolism slows down, and that means that the body burns fewer calories and stores more fat. Additionally, low T3 can cause water retention, and that combination of increased fat, lower burning of calories, and water retention contributes to weight gain. Additionally, our patient may tell us that they're feeling sad or down. Why does this happen? T3 plays a significant role in producing neurotransmitters like serotonin and dopamine, which, as we know or as we will learn, regulate mood and cognitive function. Low T3 levels disrupt this balance, and this leads to symptoms of depression, memory problems. What else? What other symptoms can we clue in to lead us to suspecting hypothyroidism? Another interesting symptom is a patient constantly feeling cold. Why does this happen? T3 is essential for thermogenesis, or the process by which the body generates heat. T3 helps the mitochondria produce energy and heat. So when T3 levels are low, heat production decreases, and we have a patient that feels cold even in normal temperatures. Another commonly bothersome symptom is hair loss and dry skin. Low T3 levels slow down the turnover of skin cells, and this leads to dry, flaky skin. T3 is also crucial in the regulation of the hair growth cycle, and without it, hair follicles enter the resting phase or the telogen phase too early. This causes hair to thin and increase in shedding. So on top of fatigue, hair loss, and weight gain, another situation that our patient might deal with is poop problems. If you've ever had poop problems, you know that's not a fun problem to have. Why do patients experience constipation? T3 helps the gut move by stimulating smooth muscle contractions in the intestines. So when T3 levels drop, gut motility slows down, and this leads to constipation because everything moves slower through the digestive tract. It's a very unpleasant symptom, and definitely one that might prompt our patient to come in. For our female patient, another not so pleasant symptom might be menstrual cycles that are irregular or unusually heavy or unusually light, or even difficulty getting pregnant. T3 affects the hypothalamic pituitary gonadal axis, and this axis regulates the menstrual cycle. So low T3 levels disrupt the production of FSH and LH. This in turn affects estrogen and progesterone levels, and this imbalance of hormones can definitely cause irregular periods, heavy bleeding, or difficulty with ovulation. In addition to the symptoms, what are our signs for hypothyroidism? So one of the most common signs of hypothyroidism is bradycardia, which is a slow heart rate. Why do patients with hypothyroidism have slow heart rate? So T3 inherently increases the number of beta adrenergic receptors in the heart. These receptors make the heart cells more responsive to catecholamines such as adrenaline, and adrenaline affects the contractility of the heart. When T3 is low, there are fewer receptors, beta adrenergic receptors, so the heart doesn't contract as forcefully. What happens is this leads to a slower heart rate. In turn, a slower heart rate, as we know, reduces cardiac output, and eventually this can lead to diastolic hypertension. So besides our simple signs and symptoms, sometimes we can have a not simple, a rare but dangerous complication called myxedema coma. Usually, myxedema coma happens in an elderly patient with chronically low levels of T3 and T4. What happens here is that some kind of stressor, such as an infection or cold exposure or trauma, puts the body into overdrive. And since low T3, T4 can't usually meet the demand of the body, a condition of overdrive definitely puts T3 and T4 at a disadvantage of meeting demand. And this puts all the hypothyroidism symptoms into overdrive. So myxedema coma usually presents with extreme fatigue that progresses to our patient becoming obtunded or even comatose, a very low heart rate, and this leads to a very low cardiac output and eventually a very low blood pressure. It also presents with low body temperatures that are beyond just feeling cold. They're sometimes so low that they're under 95 degrees Fahrenheit. Additionally to these symptoms, there's also the hallmark of myxedema, which is a non-pitting edema, or edema that when you press, it doesn't stay compressed. And this looks almost like a thickened orange peel, usually on the lower extremities. And additionally, there's some swelling around the eyes. This condition is a medical emergency. The patient needs IV levothyroxine and immediate rewarming to bring their body temperature from hypothermic to normal. So, after learning all of this and looking at all the symptoms and signs, we now suspect that our patient has hypothyroidism. How do we diagnose our patient? What do we do? So what we do is we start with ordering thyroid function tests, which start with measuring free T4 and TSH. So we already know that hypothyroidism, we have low free T4. But if we see elevated TSH, we think of primary hypothyroidism. And the reasons for this primary hypothyroidism will depend on our history, of course. If we see a patient that was recently pregnant, think postpartum thyroiditis. A recent upper respiratory infection will point us towards subacute thyroiditis, especially if there's a painful goiter involved. Without a history like that, maybe it could be autoimmune mediated Hashimoto's, and we can test for thyroglobulin antibodies and TPO antibodies and investigate more, collect more clues. In areas of the world where we know that there's potential iodine deficiency, that's what we think about, and we think about correcting the iodine deficiency. If our free T4 is low, but our TSH is also low, we think about the secondary causes involving the pituitary gland. Again, patient history will tell. Did our patient just deliver a baby and have significant blood loss? Then we think of Sheehan syndrome. If not, we're thinking of a pituitary macroadenoma that might be compressing and causing low TSH. We can think of possibly getting a pituitary MRI to add to our puzzle solving. So now, if we confirmed our diagnosis of hypothyroidism, how do we treat this? For simple hypothyroidism, oral levothyroxine, which is a synthetic form of T4, is the most common medication. We start with a low dose and adjust based on the follow-up TSH levels until our patient feels well and our TSH levels are stabilized. What do we do if we have the more serious myxedema coma? Well, that we treat with IV levothyroxine. And also, because our patient's temperature is so unusually low, we rewarm our patient with rewarming blankets and IV fluids. here, it's important to note that when we're dealing with potential myxedema coma, it's important to give the patient IV hydrocortisone until we rule out adrenal insufficiency, because both conditions can present quite similarly. And we will discuss that on a later day in our adrenal insufficiency lecture. Alrighty, team. That's a wrap on hypothyroidism. I hope this video helped you piece together the puzzle and that you enjoyed it. If you did, don't forget to hit like and subscribe, ring the notification bell for more fun breakdowns of complex medical topics. Thank you so much for watching, and until next time, keep learning and stay curious. Bye.